Okay, so the question I'm going to convert so it's more general. Doctor, what about my heart? And so one of the nice things is that the mini-gastric bypass makes some things better. Okay, so we talked about diabetes last week in clinic, and our recent survey suggests that 93% of our diabetics at 3 years are taking no medicine for their diabetes. Now, is that a cure? Are they still diabetic? That you can argue about that. I kind of maybe would define that as a cure, but anyways, bottom line is 93% of our diabetics are not taking any diabetic medicines at 3 years. Reflux, we talked about just a minute ago. Gastroesophageal reflux, it's present in in about 2/3 of our patients, about 60% of our patients pre-op, and after surgery, 85% on the survey say they're not taking any of their medicines for it, and their reflux is better. So pretty good. What about your heart? Well, there are different kinds of heart problems. One is a whole set of narrow artery problems. I have closed, narrowed, blocked, obstructed coronary arteries. And what we know is in our series, there's a lot of patients who come to us with that illness, and we know post-operatively those patients do really well afterwards. Yours is a little bit different. You're talking about what I think we could call ventricular dysfunction. Okay, and that, for people who are not familiar, is basically the heart has a job, pump blood, and it's not doing it so well. Another way that we used to call it in the olden days is congestive heart failure, or now they don't like the congestive part, they call it just heart failure, and it's actually pretty common. And so the idea there is the heart is doing a huge amount of work. If you actually measure the workload of the heart, every second of your life it has to pump, and pump effectively every minute forever. And that's a lot of work. And so some hearts have trouble with that. And it's very common, the heavier you are, the more there is presence of some of this heart failure. You can also switch it around and call it ventricular dysfunction, and there's diastolic heart failure, a lot more complexity, but I'm just going to generally use the word heart failure, which can be mild. Okay, mild heart failure. Can you run up 3 flights of stairs? Now, do you actually have heart failure, or are you just a little out of shape, or I don't know, So you can have mild heart failure, but then you can have so severe that you can't walk from this chair to that chair. Okay? Or you can't lay down and sleep at night. I can't breathe because I get such heart failure that I get fluid in my lungs. So, and that, there's something called the New York Heart Association class, 1, 2, 3, and 4. 4 is you're crippled in bed, you can barely lay down, you have to have oxygen. That's heart failure. 4, you can't walk. And number 1 means you have mild limitation. And so if you're classing your dysfunction, can you give me a number where you are?
I'd say it's probably in class 1, maybe 2.
So in general, what we're talking about is mild heart failure. Now, I'm going to tell you a story about one of my patients who had New York Heart Association functional class 4. So he was a very nice patient. I'd operated on his wife, and he came to me to have surgery, and he said, I just was at the cardiologist's office. The cardiologist told me that I have an ejection fraction of under 30%, which is really bad. He said, you need a heart transplant, but he also said, you're too big, too heavy, too fat for a heart transplant. So he basically said, you're going to die, in a nice way. So I was seeing him, and he said, can you help me? I said, yeah, because we've had people, and we have measured their cardiac function pre and post-op. So we got ready to do his surgery, got his cardiologist's advice, we got everything ready for his surgery, and then on top of that, we did his surgery and then moved him to the intensive care unit afterwards. And he was like the patients you saw here today, so he just said the next morning, he said, can I go home? So he was the first person discharged home from the ICU. And a year later, I got an emergency call from his wife in the ER. He said, my husband's in the ER. I said, oh my God, it's his heart. He goes, no, he was out rollerblading with the kids. And he fell and broke his hip. I go, before surgery, he could not walk from here to that chair without being short of breath. He had severe heart failure, needed a heart transplant. And that same guy was out rollerblading with the kids off all his meds. So we predict your heart will get better. And now back to the question of your fluid diuretic pill and your blood pressure pill. Both of them are good for your heart, and so I think what we should do on a daily basis is be in contact and determine what your blood pressure, your pulse, and your weight is every day.
Well, my blood pressure's never been high.
I know, but we don't want it to be too low either.
Right, that's,
So in other words, let's suppose your blood pressure tomorrow is 110.
that's normally where it runs.
Okay, but let's suppose it's 60.
Yeah,
So let's suppose the systolic is 60. Do you think you should take it then?
no, I know that.
Okay. So, but my point is, then we should discuss that every day. There's a likelihood that it could be, say, in the 90s or 100, in which case it might be appropriate to withhold those intermittently for a couple of days, depending on how quickly we have the arrival of the effects of the MGB. Remember, we were just talking about the MGB arrives. We have one lady who was sitting here, and she looked like she was saying with a straight face, her arthritis got better the next day. Right? We have had people whose diabetes is gone the next day. And so how your heart responds, it would make sense if it slowly got better. But we have sometimes there's a big change, a big diuresis even in the first night. And so it might not be appropriate if you've lost 1 or 2 pounds during the night to take your diuretic the next day. Especially if we mix that in, let's suppose your blood pressure was say 95 or 100. We might want to hold those one day, give you 2 days, maybe give 1 dose and see. So on a daily basis, what I would suggest with your help, do you have a wrist blood pressure cuff that
No,
you
see,
brought?
'cause it's never been a blood pressure
I know, but
I know, but so I
but
don't
now you
have
need to
that.
get
Yeah.
that. Okay, but then you need to get one.
Okay.
Yeah, it's not hard. But so part of our post-op management is answer to your question. You'll need a wrist blood pressure cuff.
Okay,
And as you probably know, they're not very accurate, right?
right,
I don't care. Because what I want is I want to measure it 10 or 20 times during the day.
okay.
And so what we'll get is, let's suppose you get a blood pressure that says it's 70. What will you do? First of all, sit down.
Yeah, probably already will be.
Well, yeah, right? And then you say, and should I take my Lasix?
I think that would be maybe a negative.
Right, it'd be a negatory. So, and if you don't have a blood pressure cuff, we're not going to get that additional information. If you just call up and say, I feel a little weak and tired, it'll be hard to have that.
Okay.
Even if the blood pressure cuff reads 70, we understand it might be telling us 80.
Right,
But on the other hand, it might be telling us 60. So we want that, and plus it'll give us a pulse rate as well.
okay.
And are you taking any beta blockers?
No, just the Atican,
Good, so we should be able to use the pulse rate too as a little bit of a guide. So those two together we found very helpful in guiding us. What we're going to be doing is going from pre-MGB to post-MGB, and what we would predict, have you had an ejection fraction done on your heart?
yeah, but it's actually high, it's in the 70s.
Okay, all right. But you still have some dysfunction.
Yeah, I have DOE, that's my biggest problem. And when they did the right heart cath is when they identified that it was the ventricular dysfunction.
Good, well, so, but another way to put your, I would kind of translate that a little bit, is you have pretty good muscular function of the left heart.
Right.
Okay, so what if we offload the heart, things like that, I bet you're going to fly. Yeah.
I'm looking forward to that.
Yeah, we think you should have a lot of improvement in exercise tolerance, and that may come rather quickly because we don't have to actually remodel the heart. We don't take a great big baggy failing heart or a gigantic thick hypertensive heart. So we may have some good options. You may have a more rapid resolution of your cardiac dysfunction than, say, somebody else with a different flavor of heart problems.
I'm looking forward to that too. That's the reason I'm doing this.
I hear you. Yeah, it's pretty exciting for us when we get to make that kind of, imagine, curing a diabetic. Imagine taking that guy who could not walk and giving him the opportunity to rollerblade with his kids. Now, we might want him to lower his expectations slightly. But he had his hip replaced, and they didn't even call cardiac